Late after lunch, so I just want to make sure that everyone is aware of the slide that's up right now. IPOKRaTES is trying really hard to make sure you have the handouts and all the information. We've been changing slides along the way a little bit to update our content as the conference evolves. But by the end of the day tomorrow, you should have uploaded here on this site all the updated handouts for you. And this is how to log on. Username is Athens, password is IPOKRaTES. So I'm going to be speaking on special nutritional considerations. And full disclosure, I was learning a lot along the way in preparing this. Not necessarily my expertise, but happy to share with you what we do in the unit. And this may be a little bit of a different style for this lecture. I want it to be interactive, lots of questions, and maybe stop in between different sections to make sure we get to that and even open it up to the panel and the other speakers. But I will start by saying that as I started to review things for special nutritional considerations for 3 conditions, chronic lung disease, the surgical neonate, and the cardiac infant, I found it reassuring because as I was going into the literature, I'm like, well, I don't really treat them that differently. I'm not sure if that was right or not in my training, but now I can actually substantiate that. And I think the take-home lesson that you can perhaps go home with or leave right now is that all the principles that we've been discussing to this point applies for these infants as well. I think we just need to be cognizant of how we maybe stray from those principles because of the management strategies that we try to put into place, thinking we're helping out the lungs, especially with chronic lung disease. But the principles essentially should be the same. So I'll go through each of these and I'll stop in between and kind of open to discussions because they're 3 very separate topics. So chronic lung disease, we've been actually bringing this up a little bit more in the talks here. So that's your typical chest x-ray that you never want to see. Thickened interstitial fibrosis and scarring, some atelectasis. And then in the septa, the alveolar septi, thickening, inflammatory infiltrates. Dr. Job talks a lot about the new BPD, where with the steroids, antenatal steroids, and you get a little bit more of the an alveolar diffuse large alveolization instead of the nice tiny multiple alveolar development. So these changes are occurring in the lung, and with those changes, there's definitely some enhanced utilization of nutrients. You want to optimize cell growth and repair. You want to provide nutritional support that may influence chronic lung disease development. The studies that have looked at how, with like a couple from Dr. Aaron Krantz that we mentioned, and he talks about that early life nutrition and the risk of the short-term and the long-term morbidities. One thing about that literature is that and one potential criticism is what came first. Was it the chronic lung disease? And that's why overall through the course of the NICU, the growth velocity was poor in these infants? Or was it the poor sort of nutritional delivery that set up the infant for chronic lung disease? So it's kind of difficult sometimes to distinguish between the two. I think the last article that we talked about where he focused in on that first week got closer and likely does impact subsequent healing in the development of disease. But this is what I meant by just being cognizant of some of the practices that we do that may impact nutritional delivery in these infants. Often we'll restrict total fluid intake. So instead of 150, 160 mLs per kilo per day, we might go down to 120 and 130. Well, doing that, you have less nutritional delivery. Dexamethasone, At least in the United States, we try to really hold back on that. I think the evidence is clear that steroids are at a cost. And because of that cost, we tend to wait as long as we can before we start any postnatal steroids, if at all. But when we do, it definitely affects your somatic growth and bone mineralization, just being two of the acute nutritional factors that it may impact. And we'll look at some of this data. Another common practice, even though I don't think there's clear evidence to suggest it even impacts chronic lung disease development, and that is the use of diuretics. Well, the use of diuretics will result in a lot of mineral losses in the urine, hypokalemic, hyperkalemic, I meant to say, hypokalemic metabolic alkalosis. A common thing you'll see in your electrolytes when you check labs on your infants with diuretics, and these disturbances will affect growth too. So if you're going to be on a diuretic, you have to pay attention to what your electrolyte's doing and be able to correct that. Again, we could have a whole different discussion whether the baby should even be on diuretics. So under nutrition, this is mainly the animal studies, but the thought of providing, again, adequate nutrient delivery for the lung is that in animal studies, they've shown that undernutrition increases oxygen-induced toxicity. You see greater histological changes with O2 exposure, an increased mortality, and a reduced lung protein synthesis. So clearly, with the lung injury or the lung growth, nutrition will affect that in its response to oxygen and injury. This is from earlier data when probably we were using postnatal steroids a little bit more commonly. How does it affect growth? Well, on this side here is the weight and the change in weight over time with the use of steroids, which is dexamethasone, which is the bottom curve, and this is your length. So clearly you will see changes in your growth. And you see it pretty quickly, I think, when you're following and monitoring growth velocity in the unit. Same changes as well in the head circumference. So overall, in this study, they showed that in the dexamethasone group, the weight change went from 138 grams per week, or 218 to 138, length from 0.9 to 0.6 centimeters per week, and head circumference from 0.8 to 0.6 centimeters per week. So steroids probably not a great idea as far as nutrition and the impact it has on nutrition. Of course, I know there's situations where you may think it's necessary. Also, here is all the same author, same paper, or same year, looking at what does it do to bone mineral content, and as well, any dexamethasone use decreases bone mineral content compared to their controls. Dr. Bell reviewed some of the other evidence of other nutritional strategies. We talked about vitamin A. Do a lot of you use vitamin A? I can't remember if he asked. Is that standard in the NICUs? No? It is for you? Only one? Well, we talked about the infiltration of vitamin A, and I think it's about 60% now of the units in the United States, but the problem is we don't have it anymore. You know, we can talk, there's drug shortages that we're experiencing. So we're a unit that used it, now all of a sudden we can't provide it anymore. So this was the original trial, where right here you see survival with chronic lung disease at 36 weeks post-menstrual age. The vitamin A group was at 47% chronic lung disease, the control group 56%. So almost a 10% reduction in the development of chronic lung disease with vitamin A. It improves lung healing and decreased susceptibility to infection, increasing the number of alveoli, and then, as I mentioned, reduces the incidence of chronic lung disease. This is also a meta-analysis of other studies, including even oral administration of vitamin A. And you see that overall, there was a trend towards a benefit to the administration of vitamin A. So this took into account Tyson's study as well as the other studies. And as Dr. Bell said, all this is available on the Cochrane database site. So inositol. So this is a, oh, the spacing looks so funny, sorry about that. It's proposed, this is a phospholipid that's proposed to enhance the synthesis and secretion of pulmonary surfactant, and that it can influence pulmonary mechanics and reduce the severity of lung disease. Not a whole lot of studies available. There's one randomized double-blind study by Hallman in '92 who showed that there was a lower inspiratory oxygen and airway pressure requirements with the intravenous use of inositol, and that there was survival without BPD or neurodevelopmental handicap at 28 days of age. So this was an earlier study. So that was their definition of bronchopulmonary dysplasia, and a reduced incidence of retinopathy of prematurity and blindness. So can this be a possible therapy for the future in mitigating the development of chronic lung disease? So to look at Hallman's study a bit closer, it was a placebo-controlled randomized double-blind study with 221 infants. Inositol was given at 80 mg per kilogram per body weight per day for the first 5 days, with the primary endpoint being chronic lung disease as defined O2 requirement at 28 days. And you see in this about 100 or so in each group for a total of 221 that there was a reduction in death and a reduction in of having a bronchopulmonary dysplasia in the inositol group compared to the placebo group. So maybe something that we may see in the future, or a potential immunonutrient to think about in the future. When looking at these kids closer, they did see that with the inositol supplementation, there was less need for inspired oxygen over time, and also a reduced mean airway pressure that was being delivered to these infants. So again, another story of an immunonutrient delivered earlier. I don't know of a whole lot of studies outside of this one that I was able to find. So back to DHA. So we were talking about it in light of neurodevelopment, especially, and then the earlier stuff that I discussed. This is data from IPOKRaTES that was just published. And so what they did is they did a secondary data analysis of their supplementation in the DINO trial, in the trial where they were supplementing the enteral. And what they found is that, see if I can find it right here, that oxygen at 36 weeks was reduced, especially in the male infants, in what they needed as far as their chronic lung disease development or chronic lung disease. So there does seem to be, and what I liked about it is because it seems consistent with what I found and what other people are finding, is that DHA might be actually very helpful in respiratory outcomes. So they did see a potential difference in O2 requirement at 36 weeks. So I wasn't going to talk about this. I had seen it, and I wasn't going to talk about it, but then it was actually brought up, and so I thought, well, let's share the data. I pulled it out, and I said, well, let's share this, because it is interesting and what you can do at the bedside even that can help reduce the incidence of chronic lung disease. So this was a randomized controlled trial on parental nutrition, oxidative stress, in preterm infants. And what they did is they had 4 groups, 20 in each group. They provided one group with dextrose and amino acids, another one the same plus lipids. The third group the same plus multivitamins. The fourth the same plus trace elements. And then they substratified so that each group was actually divided into 2, again, with 10 each. Whether the PED was photoprotected or the lipid ed or photo-exposed. The outcome was the incidence of chronic lung disease, and for sort of oxygen radicals, they looked at urinary peroxide levels to see if that was part of the pathway of what they would observe in chronic lung disease. They did see that urinary peroxide levels were linked to chronic lung disease, not so much in the other outcomes when they measured these changes in the urine. But where was this coming from? And there were 2 sources where it was mainly coming from. So if you kind of remember that first group was just dextrose and amino acids. So 1A is the photo non-exposed and then the photo exposed. So not much difference or anything going on there. And this is with chronic lung disease or mortality. Group 2 was the addition of lipids. So no change here, but with the light exposure, photo exposed, a tremendous change. In 3 was the addition of multivitamins. So at baseline, even not photo exposed, an increased level of urinary peroxides, and then even more so with light exposure. This was the addition of multivitamins to the previous cocktail, and then photo exposure. So the exposure to light on the parental nutrition was strongly linked to the incidence of chronic lung disease. So the same principles, like I was saying with chronic lung disease, as we were discussing before. You want to be cognizant about the early period, the early first week of nutrition, as Erin Krantz shown, and keep your babies in a positive nitrogen balance, improve amino acid profiles to improve overall growth. We've discussed that. No change here. Just know that if you're going to fluid restrict, that might be a bit more challenging. You want to try to achieve about 20 grams per day of weight gain to promote lung growth, an enteral diet to support a growth velocity. Another thing that I'm going to talk about that's talked about before, but I want to mention especially in the next section, is what part of your macronutrient that you're delivering that enables you to achieve what you want to achieve without the potential side effects. So with the increase in calories or increase in nutrient delivery or energy delivery, you might not want to provide it as a glucose or a carbohydrate source, and we'll explain that. It's been explained, and I'll review it again. Vitamin A, unfortunately, at least in the U.S., we're not able to get it. PUFAs that we have talked about. And really to try to avoid postnatal steroids and diuretic use, as both just complicate, I think, the nutritional strategies at the bedside and have never really been shown to reduce chronic lung disease or make things better. It's sometimes hard to make those changes or to be strong about it at the bedside during rounds, because I think those are thoughts that everyone has that it might help, and you want to do anything or you can possibly can to help these infants. However, I've seen mostly that it's just time, and it's time and adequate nutrient delivery that gets these babies eventually off oxygen and ready to go home. So before I leave chronic lung disease, are there any questions or challenges that you have had that you want to bring up and discuss now before we go on to surgery? Oh, yeah, no, you said that last time, right? I should have remembered that when Dr. Bell was talking about it. Absolutely. No, yes, we start all of our babies very early on caffeine. Good point. Helps chronic lung disease as well as neurodevelopmental outcomes. Absolutely. There's been no study to show that diuretics, even after bronchopulmonary dysplasia, helps you manage the chronic lung disease during the course of the NICU, during the course of their stay. Not to say that occasionally when you feel like you've got to try something and you try, but most of the times they're not helpful and they just complicate your nutritional strategies, and then you get into electrolyte disturbances, and I don't really see a long-term benefit in a routine use.
What about the use of inhaled steroids and bronchodilators?
I was trying to stick to nutrition, but I'll go with that too. Likewise, I don't think there's a lot of great evidence that even the inhaled steroids work that well. I think I don't know if you guys want to comment in the back, but it's not something that's infiltrated our practice because the strong evidence just doesn't exist.
Inhaled steroids have crept into our practice as a way of dealing with the concerns about dexamethasone effects on brain development. So we had a hard time giving up steroids altogether, so we started to use inhaled steroids, but I agree the evidence is really sparse. but hopefully we're not getting systemic effects and not getting effects on brain development. One of the things that you showed on a previous slide, but you didn't mention in your recommendations, was photoprotection. Did you want to say a word about that?
This is the study I reviewed actually because of, because of what you had mentioned before, Dr. Bell. So I inserted this study. I'd seen it, but it wasn't going to be originally part of my talk. So this is the study showing that the exposure to light is linked to chronic lung disease. You're right. Overall summary slide, I can add it before it gets uploaded to the IPOKRaTES site.
What happened with Inositol since '92?
Maybe a study needs to be done. Are there? I agree. I thought it was very intriguing when I was reviewing the different nutrients that haven't been studied or followed up that had once shown an association to chronic lung disease.
What about steroids for women give babies for many days in ventilator?
Yeah.
Just for a few days, just to take
Right.
off from ventilation.
Yeah, we hardly use postnatal steroids now, and I say hardly because it's not that we never use them. And so how we'll use them now is there's another study that talked about the risks, benefit, cost of steroids in long-term neurodevelopment, and you get to a point in your care where the chronic lung disease and the BPD and its associations and risk for neurodevelopment start to exceed that of the steroids. But it's late in the course, and so what we'll do is that we let the babies be pretty old, or if they're rapidly deteriorating, and then we'll do a course of steroids, but it'll be in that sort of 5 to 7 day range of dexamethasone. I can share with you our tapering schedule and stuff.
Perhaps I didn't understand well. What about the use of vitamin A? How and when? In the
So we,
TPN?
It's 5,000 units 3 times a week for the first 4 weeks of life. Yeah. I am, thank you. Vitamin A? We're in a delay. Yes, you can get it, but our manufacturers where we were getting it from, we currently are in a shortage and we don't have it. We're waiting for them to turn it around and replenish their supply. But we routinely used it in our NICU.
Another practical question. Thank you for your talk. Again,
There you
it's
are.
me again. The inositol is orally given or parenterally?
It was given IV during the first 5
IV.
days. Yeah. In this
Because we have a
study.
problem giving either vitamin A intramuscularly or other medications with IV because we consider that we produce a lot of pain to the babies and we may have side effects even in local
Yeah, you know,
intravenous.
I think that's
So-
I think that was a common concern. I think that was part of the buy-in even in the unit. I think that's actually why it's not been, even though there's not that many studies that have been, you know, in a meta-analysis showed a definite proven benefit of what we do in the NICU. And there's a few drugs that actually do that. And vitamin A was one of them, rigorously studied and showed in fact, yet neonatologists were very reluctant to implement it, even though we implement a lot of other things without much thought. So I think part of it was just, you know, the 3 times a week IM injections in thighs as big as your finger and what kind of potential infections and other things you would introduce. And so that is part of the buy-in, but I'll tell you, we did not see any of those issues, and I don't believe any of those issues were concerned in the major trial. Yes,
So
Dr.
we're
Dahl.
left with espresso now, huh? Only caffeine by mouth.
Well, right now, we'll resume vitamin A once we get it. Unfortunately, we're experiencing a lot of different drug shortages in the United States right now.
As I said, we started vitamin A after discussing it for some time, and our hesitation was based on the concern about intramuscular injections. But in fact, our nurses used the smallest needle that's available. I think it's a 30 or 31 gauge needle, and although they were concerned about this, they say that the babies don't seem to mind it at all. We have the same problem with lack of supply at the moment. It may be that vitamin A could be given enterally if we knew what the correct dose was, but the studies to date have not shown that you can achieve the same kind of levels with the doses that people have tried. With respect to inositol, it can be given intravenously or orally. There is a large trial going on in the U.S. now by the NICHD Neonatal Research Network, and we're looking at two primary outcomes. One is reduction of BPD, and the other is reduction of ROP, because in the Hallman studies, he also found a decrease in retinopathy.
Are you giving it IV or orally, did you say?
Giving it IV initially and then switching to orally. And we've we've been doing kinetic studies for several years to figure out the correct dose and to look at how frequently to dose it.
Excellent. So when will that trial close, do you know? When do we get to hear the results?
We're hoping it'll start in 2012.
Oh, gosh, okay.
So it'll probably be 3 or 4 years.
So when IPOKRaTES comes back to Greece, we all come back and get to share the results? Excellent. All right. Oh, okay. Okay, good. So surgical neonates, and this is where I'll say I learned the most, because I was under the impression, or as I was thinking about this, is, gosh, they just had surgery. They must need more. They must be more catabolic, and what are the changes we need to do at the bedside? Well, there's been several studies looking at energy expenditure compared to control infants, or even compared to the same infants. And so Dr. Jasek is at Boston Children's Hospital, and he asked, do critically ill surgical neonates have increased energy expenditures? And here he controlled, these are to the right are the kids on ECMO, and then control infants that were in the NICU but not required, term infants that did not require ECMO. And you see, in fact, their overall energy expenditure was not that different from the control infants. He did a similar look at energy expenditure, looking pre-op and post-op to PDA ligation. And again, same infant, so this is paired data before they went to the operating room, after they went to the operating room. And you see that their expenditure, total energy expenditure, was not different than compared to pre-op. And in fact, he further analyzed data and showed that what you're delivering and the nutritional delivery that you were doing pre-operatively, that you were happy with the hydration and the energy needs and the overall growth, actually correlates almost exactly to what they'll need post-op. So another view of looking at that their total energy requirements or nutrient delivery actually didn't change that much. The only change that someone did see in looking at energy expenditure was an increase in that energy expenditure, but really within sort of 4 to 6 hours afterwards, and then starts to return to baseline. So if there is any acute change in an energy expenditure after an infant receives surgery, it's just that, acute, right afterwards, but returning to baseline soon thereafter. So why is this important? Well, we've heard in other scenarios that you can overfeed an infant. And overfeeding can come at a cost that you don't want to necessarily have to deal with while in the NICU while trying to manage these infants. And the one thing we talked about with the overfeeding is that as you increase your caloric intake, and mainly with glucose and carbohydrates, you're actually increasing CO2 production. And we've talked about it. That's what I mean. Principles are almost the same. It's a readjusting and seeing that even in the surgical neonate, expenditure is not that increased. You want to be careful with what you're providing, and understanding an automatic increase in total energy may actually have an adverse effect on what you're trying to achieve. And that increase in your caloric intake can also be associated with increased hyperglycemia. And any increase in your hyperglycemia in the NICU in a surgical infant, and this is data that I'll show you from Cleveland, Dr. Charles, he similar theory and in research to Dr. Jasic, that these nutritional intakes can then have that opposite impact in your surgical infants. Longer ventilation and increased length of stay. But you can try to avoid that, or that can be avoided by not automatically increasing your total caloric intakes. Here you see that they measured length of stay in days, and then infants that had a maximum glucose of over 120 mg per dl or less than 120. And you see that when you were above 120, you had a higher or longer length of stay. And this hyperglycemia, same group, was also associated with increased mortality. And so you see here the non-survivors, what their maximum glucose values were compared to those that survived. These are all surgical infants. So surgery, I had another slide. It also, again, with the respiratory, the longer the ventilation too. So if you're increasing your caloric intake, increasing hyperglycemia, the CO2 production, your longer days also on the ventilator in addition to longer stays. So surgery does not result in high increases of energy expenditure, automatically increases in energy delivery, and calories are not necessary. And just any take-home lesson that there is a concept of overfeeding, and just like we can do that with our IUGR infants, just like we can do that with the other infants, we can also do that with our surgical infants. And so kind of take away the sort of the myth that they automatically would have an increased needs because of increased energy expenditures. Any thoughts on the surgery or post-surgical care? Yes.
I hadn't seen the hour-by-hour effect on energy expenditure with surgery, but it was quite interesting. And this initial rise could very well be explained by cold stress in the OR.
Mm-hmm. Yeah, thank you. Okay. So for the cardiac infants, now they are a little different. So in children with congenital heart disease, less than 2 years of age, and actually even maybe a little bit older, there's a really high prevalence of malnutrition. And the younger the patient, the worse their malnutrition is. And it's more common, it appears, in the cyanotic infants than in the acyanotic infants. And sort of the feedings and the reviews of looking at our cardiac patients and how well they're growing, again, reminds me a little bit of our neonatal literature, is that the current feedings that they provide right now really don't provide enough calories to sustain an infant with congenital heart disease. And they've provided the same sort of studies that we have looked at in the NICU in the premature infants, where providing more energy and calories has helped with their overall growth. However, these infants do remain uniquely difficult to establish good overall growth. Here are some data with their growth failure. I'll add the reference to it. And then you see here that when they looked at congenital heart disease and weight, height, and weight for height, this was at baseline before they went to the operation, and this was afterwards. And even though there was in follow-up, and even though there was some improvement in their overall Z-scores of each of these parameters, again, not uncommon of our infants, these parameters didn't necessarily normalize. So getting enough nutrient delivery because of congenital heart disease is a challenge. They do have an increased higher metabolic rate than the healthy neonate in control. So this is different again from the surgical data, but what's not different is that their energy expenditure, I'm going to find it, Well, maybe on another slide. What's not different is their energy expenditure is the same as it was before going to the operating room. So overall, energy expenditure needs increase in congenital heart disease, but what's not different is it's not going to be any different pre or post-op, just like a surgical patient. So the same strategies you were using before going to the OR to maintain nutritional intake and growth, the same strategies will be in place afterwards. They also showed very similar that the resting expenditure may change a little bit right after surgery, but it declines 24 hours after surgery, but then returns to normal within about a week's time is their time frame studies that they looked at. So a little bit of a change around the time of surgery, but afterwards their post-energy expenditure needs the same as their pre-expenditure needs. Another way of looking at their total energy expenditure and how with congenital heart disease it is increased compared to controls, which was unlike what we saw with the ECMO kids compared to controls in the surgical neonate. I was a little surprised by this data, even though it's in 2011. He looked at what it took to keep babies with congenital heart disease in a positive nitrogen balance. And I was only surprised because it seemed a little bit lower than what we had been talking about. But the amino acid delivery or protein intake of greater than 55 kcals per kilo per day, energy or protein of 1 gram per kilo per day seemed to get these kids in a more anabolic or a positive nitrogen balance compared to the kids who were not in that state. So those were general parameters, but we already know our parameters are a little bit more than that. So I don't think, again, we have to change necessarily much of what we're doing for our babies in the NICU with congenital heart disease. Where the establishment, and I think we've all seen this post-operatively, is really the transition to PO feeds. So I think that's where one of the biggest challenges comes from after they return to us, and as we start to transition them from IV hydration and nutrition to PO, and that's just the ability to getting them to PO feeds as they recover from their heart disease. And here are two sets of patients with transposition or hypoplast, and you can see that this is days, this is the percent of full enteral feedings. And with transposition, they did it a little bit faster, but also, taking them about a week and a half to get to that point where a hypoplast would take a little bit, or a hypoplastic patient would take a little bit longer. But sort of transition times that we see even in our smallest babies, and that's where I think a lot of the attention for us in the NICU has to be about that transition to getting them into full enteral feeds, and then providing enough calories and nutrition to keep up with their total energy expenditure, which is higher than other term infants without congenital heart disease after going home. Okay. Yes, Dr. New.
Hypoplastic left ventricle babies versus the transpositions. And you wonder if part of that may be due to it's an artificial effect where the doctors taking care of the hypoplastic left ventricle babies are afraid that they're going to have ischemic bowel disease. And that is, it just comes across as something that
it's
certainly
sort of practice-derived or
practice-derived rather than actual, the difference between the babies. It's maybe the fear that the physicians have.
I think that's a fair point. I think that's an absolute fair point. Because there was nothing else to show, whether O2 consumption was different between the two groups or anything else to suggest that their ability to be able to transition to PO feeds was more, it was utilizing more energy expenditure and unable to do so.
Thank you very much. May I come back to the surgical patient?
Yes.
We know that after surgery, minimal or bigger one, you have fever, or it is not the normal temperature in any way. Does this mean actually an increased metabolism? And if this means an increase, it means possibly inflammation. It means inflammation that leads to increased metabolism. And increased metabolism does not lead actually to consumption of energy?
That train of thought, absolutely, I would agree with that. However, what surgical patients, like what example would you see? I don't think I see a whole lot of, especially if we take the PDA after a PDA ligation in the NICU, a whole lot of fevers, post-operative bleed. But you're right. I think there's going to be deviations to this, and if an infection occurs or they start to have fevers or other things that might increase their overall energy expenditure. But I think sort of an uneventful post-op recovery, their total energy expenditure seems to match their pre-op needs.
Mm-hmm. And fever? Do they have even some degrees of fever or the decimal fever?
I'd have to, I go back to, honestly, back to how I was trained, thinking that fever increases your energy expenditure. Have I seen a paper to actually show that? I haven't read one, not that it doesn't exist. But I just don't think I see a lot of, outside, again, if something acute is changing with your infant in the NICU, a lot of routine sort of post-operative fevers.
Can we explain the so high rate of chronic malnutrition in cardiac patients?
Yeah, a lot of the authors of these papers came up with two possibilities. One was the cardiac function, your cardiac functional ability and pulmonary blood flow and O2 consumption, whether there was something physiologically about the circulation, especially pre-op, waiting for your definitive surgery. Was that impacting in any way what your needs were? Because again, unlike the other kids, they had higher energy expenditures and greater needs than control infants. So whether it was physiologic, and then versus just mechanical as well, being able to allow them to sufficiently being able to take in what they need by all PO and not having to go to other strategies to make sure they get the complete nutrient delivery. So I think it seemed to be both, sort of their physiology and what's happening with their physiology, as well as just mechanically being able to compensate against that as well, to take in all your feedings by mouth and enough volume by mouth to do so. And then not having the sort of, and not supplementing what that by mouth nutrition may be. If they can only take in 100, 120, 130, well, that may be okay, and actually surgeons actually might like that volume, but you just may need to increase the content of what you're providing. We will in the NICU. They didn't. There was discussion. A lot of people to be able to having to do so or to think about it. There wasn't a whole lot of strategies in doing so, but we will in the NICU. Anything else? So it's, what time is it? It's do we have 10 minutes left? I didn't know whether we wanted to end the day like yesterday with open-ended questions for all the speakers or not. Yeah, if everyone. The one thing too, and this will help me for tomorrow, and I'll just throw it out there, is that I'm going to be speaking tomorrow morning about necrotizing enterocolitis, but the questions I've been hearing along the past couple of days have been informative to me, and I want to make sure I address what your concerns were. So go ahead and just, I'm not necessarily going to answer them now, but anything you absolutely want to hear about related to necrotizing enterocolitis. I might be sorry I asked this because I might be up all night, but I want to make sure I get to. I'll write it down. I'll do my best.
Type of formulas that you use to babies after surgery, or even just conservative treatment of babies with necrotizing enterocolitis, and your feeling about those hydrolyzed amino acid formulas like the Neonates that we use here in Greece.
Okay.
Could you also address necrotizing enterocolitis in term babies?
I've got those slides for you already.
Okay, and also in late preterm babies. I mean, between 34, 36 weeks old.
All right. I'm going to leave that to Dr. New. Is that okay, Joe, that you're going to do the probiotic part?
That was my intention.
Awesome. So we'll touch upon that. Anything else? All right, good.
Some new
PDA association with that? PDA?
concerning blood transfusions and
I was afraid you were gonna say
relations to
that.
necrotizing enterocolitis.
All right.
And also, what about the stage 1?
Yeah,
Neck.
okay.
Possible association between neck and highly contaminated breast milk,
Huh.
and also lactoferrin.
Yeah, that's a good one.
Bacterial contamination, for example.
Okay. All right. Perfect.
I would like to know if there are difference in feeding a surgical, after a surgical neck, when ileocecal valve was removed.
Yeah.
If there are any differences.
So maybe I extended a little bit to talk about short bowel syndrome and the risk factors for that.
Okay. Yes. Thank you.
All right. Well, I guess I'm not going to sleep.
Next, you.
I can help you.